them, but they have handled it very well. So at the end of the day, it was a wonderful case.
Thank you. Thank you. Thank you.
Bismillahir Rahmanir Rahim. My case of discussion is physiology of serial lesion. I am Dr. Muhammad Suleiman from Peshawar Institute of Cardiology. My patient was a middle-aged lady with diabetes. She presented to us with unstable angina. Her biochemical profile was normal and her ECG and echo was unremarkable. Her angiogram revealed distal left main 50% stenosis. There was another moderate lesion in the proximal LAD and another very tight stenosis at the distal segment of the LAD. However, her left circumflex artery was free from any significant disease. Her right coronary angiogram revealed proximal moderate to severe stenosis. Given her age and diabetes, she was referred for CABG. However, surgeon questioned the severity of left main and potential Lima failure after CABG. She was referred back for the lesion assessment. Okay, now the question was how we can assess predict the Lima patency in future. Is it either intracoronary physiology or intracoronary imaging? The studies have shown that Lima patency depends on flow competency, which in turn can be predicted well with intracoronary physiology. So we decided if it's physiology positive, we will refer back her to the CABG. However, there was a catch. We were thinking that this distal LAD lesion might affect the physiology of our proximal lesion. One of the methods to address this issue is FFR pullback, in which a pressure wire is pulled back during hyperemia across all the serial lesion to identify the lesion with highest pressure drop and fixing it with PCI and then repeating the process till FFR become normal. However, we were not performing any PCI, so this was not as an option. So after wiring LAD with a comet pressure wire, without crossing our distal lesion, we calculated FFR, which turned out to be 0.88. As this FFR was functionally non-significant, so the question was, should we defer revascularization in this patient? The studies show that in presence of a distal stenosis, the FFR of a proximal stenosis can be underestimated. So our FFR might be false negative. How about IFR? We calculated IFR of this proximal LAD and left main lesion, and it turned out to be 0.89, which is functionally significant. Now we wired our healthy left circumflex, which was free from any significant disease, and we calculated FFR over there, and it turned out to be 0.79, which is again clinically significant. Now we calculated IFR in this vessel, and it turned out to be lower than LAD, that is 0.83. Just a reminder, the previous one was 0.89. So now there is a discrepancy between LAD and left circumflex IFR. So why there was a mismatch? The studies have shown that in serial stenosis, IFR is superior, and the reason for that is IFR is dependent on the resting blood flow. But if it is dependent on the resting blood flow, why IFR of LAD and left circumflex was different? The same study also showed that IFR can be affected if distal lesion is very tight and it affects the resting blood flow. In our case, it was very tight, like 90% stenosis. So this might be the case, the reason that our left circumflex IFR was lower than the LAD IFR. In terms of outcome, if there is an IFR and FFR mismatch, the studies have shown that IFR leads to better prediction of coronary flow reserve and prognosis of the patient. In conclusion, intracoronary physiology in serial stenosis can be deceiving, and due to lesser vulnerability, IFR may be better alternative in such cases. FFR pullback is always an option if PCI is needed to be performed, and if you don't have any IFR in your cath lab, FFR can also be performed via normal side branch to avoid the effect of distal stenosis in proximal lesion. Thank you very much.
And now I request Professor Bilal Moeddin for comments on this case.
Thank you. Let me put it this way, that if it was me, I would not take this patient in and do an FFR study. It is economically unviable.